Good afternoon, everyone. Welcome to our Life as Clinician-Scientist event of the Australian Academy of Health and Medical Sciences on rural and regional life as a clinician-scientist. This is our second online event in the series in relation to rural and regional life as a clinician-scientist, and it's wonderful to be with you all here today. I'm Louise Maple-Brown. I'm the chair of today's session. I'm a clinician scientist based on beautiful Larrakia country in Darwin. I'm an endocrinologist at Darwin Hospital and a researcher at Menzies School of Health Research. I've lived and worked here in regional and remote Australia for over 20 years, working across remote communities in all of the Northern Territory, as well as in rural and remote Western Australia and North Queensland. I'd like to start by acknowledging the traditional custodians on the land on which we're all meeting today and pay my respects to elders past, present and emerging. I extend that respect to all Aboriginal and Torres Strait Islander people joining us online today. Aboriginal and Torres Strait Islander people were the nation's first scientists, and they remain the spiritual and cultural custodians of their land. I particularly like to pay my respects to the Larrakia people as the traditional owners of the land of Darwin, where I live and work, and coming from you today. So firstly, you can view today's program, including speaker biographies, online using the QR code on screen, as well as the full program. We're delighted you've all joined us today. For many, perhaps this is your first step towards embarking on a career combining clinical practice with research. Perhaps some of you are already on this journey and looking for advice on how to stay the course. Perhaps some of you aren't quite sure yet exactly what you want to do, but the fact you've joined us here says you're committed and intrigued and thinking about how your clinical life might one day merge with research in regional or rural parts of the country. We have some wonderful speakers joining us from across the country today who will speak to you about their own career journeys and how they've come to find success as clinician researchers, and particularly how success looks different for everyone, and even more so on the backdrop of working in outside of urban settings. You also have the option to ask questions to our speakers. We encourage you to do so at any time throughout the presentations. This is your chance to ask that burning question. We'll ensure there's plenty of time at the end to answer as many of them as possible. To ask a question, you need to exit the full screen mode to see the Q&A side to the side of the video. Just type your questions in and we'll see them. I'd like to thank our Platinum partners. This event wouldn't be possible without the generosity of our partners. We're very grateful, firstly, to the Platinum partners of Deakin University, Murdoch Children's Research Institute, the George Institute for Global Health, the University of Melbourne, University of New South Wales, and the University of Sydney. We're also grateful to our gold partners and program supporters from around the country who are all invested in the future of Australian health and medical researchers. Our sponsors support the program because they know the value of clinician scientists and they want to support you in following this career path. So now for a little background about the Academy, the Australian Academy of Health and Medical Sciences. We're Australia's authority on and a trusted voice of health and medical science. Our 550 fellows are the very best of Australia's health and medical researchers and clinician scientists. We're a bridge between science and society. We connect the best evidence and expertise to the decisions that matter. Our vision is for a healthier Australia in a healthier world, driven by science, guided by evidence, and grounded in public trust. We work to bring about the vision through our purpose, which is to improve health outcomes by providing independent, evidence-based leadership that bridges science to policy, practice, and public understanding. We deliver on this through our 4 strategic pillars, which are written there on the slide. Our Life as a Clinician Scientist program is a critical part of our efforts to build national capability by inspiring and supporting people like you to follow this career path. So the Life as a Clinician Scientist program is now in its 11th year. We've had more than 200 speakers sharing their wisdom at more than 35 events. Thousands of people have benefited from these events. You'll note we're recording the presentations today, and these, alongside over 150 other inspirational videos, will be available on the Australian Academy of Health and Medical Sciences YouTube channel in coming weeks. If you haven't already, consider joining our mailing list so that you can stay up to date with news and opportunities in the health and medical research space. It now gives me great pleasure to introduce our first keynote speaker, Professor Jane Davies. Professor Davies is a Senior Principal Research Fellow at the Menzies School of Health Research and Co-Director of Infectious Diseases at Royal Darwin Hospital. Her research focuses on understanding and optimising care for viral infections with a focus on Aboriginal and Torres Strait Islander people in the Northern Territory of Australia. She leads the Hepatitis B PAST program, a holistic model of care co-designed to deliver care on country for viral hepatitis and liver cancer screening. Prof Davies works clinically as an infectious diseases and general medicine physician at the Royal Darwin Hospital and leads the clinical viral hepatitis service. Please welcome Professor Jane Davies.
Thank you so much, Louise, for that really kind introduction, and thanks for having me. I would like to echo the acknowledgement of country. I'm also on Larrakia land, and I'd like to pay my respects to elders past, present and emerging, and really extend that respect to any Aboriginal and Torres Strait Islander people who are listening online. I'm going to talk about elevating equity in infectious diseases care through partnerships. And I thought that first of all, I would just give a little bit of context to where I am working and the kind of topic that I've spent most of my time concentrating on over the last 10 to 15 years. So hepatitis B and liver cancer in the Northern Territory. You may or may not know that Aboriginal and Torres Strait Islander people are 6 times more likely to get liver cancer, and in Northern Australia, that's very directly linked to chronic hepatitis B prevalence. You can see the heat map there with the north of Australia being red, and that's liver cancer prevalence, but also chronic hepatitis B prevalence. Prior to 2010, only 3% of people were receiving antiviral treatment for their hepatitis B, and only 1 in 10 liver cancer cases in Aboriginal people were diagnosed by screening when you have the best chance of a good outcome. The average survival after diagnosis was 64 days for Aboriginal people, which is clearly horrific, and 173 days for other people. The most at-risk populations live in really remote communities where there's lots of challenges to access. So then I thought I'd give you a bit of context about me. So I have not always lived in the Northern Territory, as you probably have guessed already from my accent. So I came from the UK in 2010 to Darwin. I was coming for a year of tropical medicine experience because I was working at the Liverpool School of Tropical Medicine and the Royal Liverpool Hospital in the UK. With a population of 67 million people, very densely populated on a very tiny island, and a cool and temperate climate, very urban, very built up, very tertiary referral centre. And then I arrived at 5 o'clock in the morning at Royal Darwin Hospital, straight off the plane and into the hospital accommodation. And, you know, so different, very sparsely populated, tropical conditions, population 150,000 across the top end really, and only 220,000 across the whole Northern Territory. Wet and dry seasons, something that I was not really used to, and very much a hospital that cares for Aboriginal and Torres Strait Islander people, being about 60% of inpatients at any one time. So I very quickly met some incredible people, some of whom are pictured on this slide and many of whom are not. And I think my first message is that it's the people and the relationships and the mentors, and the finding people that you admire what they are doing. That was really important in me staying in the Northern Territory and not going back to the UK in 2011, which didn't eventuate. So another thing about the Northern Territory is the distance and disparity. And again, just to give you a little bit of a flavour of what that looks like. So for hepatitis B, to get a viral load result from a remote community takes around 3 weeks to get the result back. An ultrasound for your HCC screening is a 2-hour small plane flight away. The life expectancy for an Aboriginal person in the Northern Territory is 15 years less than a non-Indigenous person, and the prevalence of illness and disease is disproportionately high. So a population of 159,000 people in the kind of urban and regional Darwin area, and there's 100,000 episodes of care through Royal Darwin Hospital roughly per year, around 60 to 70% Aboriginal people. And in remote clinics, or 89% of presentations are Aboriginal people. The workforce is very transient. It took me a little bit of time to realise how important that is and how that really impacts on everything that we do working in a rural and remote setting. There are a lot of fly-in, fly-out professionals across all sectors, not just health. There's often staff shortages, there's lots of complex logistics, and distance is definitely an important factor to take into consideration. So where did my journey start? So I worked clinically for a couple of years, 2010 and 2011, and then I got embroiled in a PhD looking at hepatitis B in the Northern Territory. And this was really the beginning of my clinician-scientist kind of research story, I guess. And, you know, we found a really interesting thing that the hepatitis B is a unusual subgenotype in Aboriginal and Torres Strait Islander people in the Northern Territory. It's only ever been found in Aboriginal people. It's called C4, and unfortunately it's aggressive from a phenotype of disease, and so progresses to liver cancer and cirrhosis fairly rapidly if you compare it to some of the other genotypes across the world. So I was able to really, I guess, do that high-level science and then really reflect on, at the end of my PhD, well, what does this actually mean, and what is the value of us having this information in terms of trying to improve healthcare for people living with chronic hepatitis B in the NT. And then that's where the real collaboration and the learning and communicating and partnering with Aboriginal people across community, health workers, and also academics came into play. And in 2014, we set up an Indigenous reference group, and this group still meets twice a year up until now, and has really been the cornerstone of how I have been guided through my research journey, and how the co-design of all of the work that I have been involved with has really gone through this Indigenous reference group process. Representation from about 14 communities across the Northern Territory. Obviously, people have come and gone along the way, but we've had a core group of people who have been there since 2014 as well. And really, again, one of my key learnings is that this is the group that have really enabled me to progress and do the things that I've ended up doing. So fast forward a little bit to 2018, and we have a grand plan to act on the information that we now have about this aggressive subgenotype of chronic hepatitis B, and to work in partnership to eliminate chronic hepatitis B from the Northern Territory. That's our aspirational goal. And again, you've got to aim high, or you know, you might not achieve exactly what you aim, but you might get somewhere close. So we're aiming to eliminate. And I just have to say, say this was before WHO decided they were going to eliminate chronic hepatitis B. They published their guidance in 2016, and we started talking about it in 2014. And then in 2018, we got some funding from an NHMRC partnership grant, which we called Hep B Past. And that partnership now continues through another partnership grant called Hep B Past Plus, and has evolved and grown iteratively over that kind of almost 10-year period. And these are now all the current partners. So lots of Aboriginal medical services across the Northern Territory, but also now national peak bodies for viral hepatitis, for cancer, for Aboriginal and Torres Strait Islander people. And really the whole programme of work was based around partnerships, and it is based around trying to achieve equity for Aboriginal and Torres Strait Islander people using participatory action research methodology throughout the whole programme across every aspect. So continually going through this cycle of collaborative co-design with key stakeholders, developing things, implementing them, evaluating them, and then coming back to the key group of stakeholders. And we've been able to iteratively develop a model of care for chronic hepatitis B to implement within a Northern Australia NT setting. A really huge part of that was that at the beginning of this journey, there was no health information about chronic hepatitis B in any Aboriginal language that was available publicly. And so that was one of our first tasks, was to try to enable that to happen. And again, it was a co-designed, very collaborative process, but now we have the Hep B Story app, which is currently available in 11 Aboriginal languages, with ongoing work on additional languages all of the time. Again, very key learning that Aboriginal health workforce in Aboriginal community medical services are the most important people to enable things to happen and to enable continuity and sustainability in a setting where people come and go very frequently. And so we really focused on, as part of the model of care, building capacity within the Aboriginal health workforce. And again, a co-designed course. An exceptional artist called Philip Wilson, who's also an Aboriginal health practitioner, helped us develop this framework, which he then drew that beautiful art diagram of, which can be used for developing culturally safe training for the Aboriginal health workforce. So we co-designed it, implemented it, evaluated it, and then have translated this model of training to other things. The first one being COVID, because that came along around that time, and then more recently syphilis, and more recently even to the last few months thinking about diphtheria in the Northern Australia setting. And so 221 Aboriginal health workforce have now completed this course and evaluated it as helpful. In terms of enabling care to be delivered in a vast remote setting, we set up this hub and spoke model, where we have an outreach support team that goes to support primary care to deliver. The vast majority of Hep B care can be delivered in primary care, but you do need access to FibroScan and ultrasound, and sometimes a specialist, but not that often, but you sometimes do need to link into the hospital care. And so we do a lot of remote outreach trips where we do this one-stop shop where people can access everything that they need on that one day. And I guess this brings together the education in first language, the training of the Aboriginal health practitioners who work with us in those clinics, the access to mobile equipment, and really bringing that all together to roll out the care and then to evaluate that and see whether it's working. Another aspect was that we established everybody's Hep B status across all of those partner services, so that we really were not leaving anyone behind, with this real focus on equity. So does it work? So this holistic model of hub and spoke care, with all of that wraparound education and a kind of participatory action research approach, very much in partnership, yes, it does work. Where this programme of work and the partners involved are the only services achieving the national strategy targets for chronic hepatitis B care in the country. This is our evaluation in 2023. The red lines are the national strategy targets. So diagnosis were 99.9%. Everybody's got a status, and that's across around 50,000 Aboriginal people who are involved in this partnership. 86.3% of them, if they have Hep B, are engaged in care, and 24.1% on treatment, with that target at 20% for the national strategy. Have we achieved equity? Well, yes, we have in the Northern Territory. So again, one of the only places to close the gap for a specific disease. So for chronic hepatitis B care, engagement in care, this is national data that shows that Aboriginal and Torres Strait Islander people have a higher care uptake than non-Aboriginal people in the Northern Territory. We're also able, as well as that implementation, to focus really on the C4 genotype and try to establish as much on a kind of more lab-based science perspective, working really closely with Vidral and with the Doherty Institute to look at C4 in more detail and learn as much as we can to then transfer that knowledge into the programme. Liver cancer is the consequence of hepatitis B over time. And as I mentioned at the beginning, the outcomes for liver cancer in the Northern Territory were terrible pre-2010. They're still not, not fantastic, and there's still a lot of work to do, but they are improving. And if we look at the time since the implementation of the programme, we can see that the survival for Aboriginal people has increased 3 times, so 300% higher than it was prior to the programme. So then we were able to then pivot all of these relationships, all of these partnerships and these co-design methodology and frameworks to the next thing that came along, which at the time was COVID. And so really using those partnerships, we were able to develop vaccine information videos fairly rapidly in comparison to how long it took us to get the Hep B ones up and running because of the time pressure. And so we did that in 17 videos in 10 languages to enable people to make informed choices about vaccine delivery. And then we were also able to look at the immunology of response to vaccine in Aboriginal people. And so this again was a partnership with the Doherty Institute and Catherine Kadiska's lab there, doing some very clever and incredible T-cell and antibody immunology to look at how COVID vaccines were working in Aboriginal people. And then also we did some qualitative work alongside that. And then people started to come to us and say, well, actually, we want to look into this and we're worried about this. And so this more recent long COVID study is because the Aboriginal Medical Services were really concerned and are still really concerned, and we don't have the answers to this yet, that more people seem to be randomly dying, having kind of sudden cardiac death post-COVID than they would expect pre-COVID. And clearly there's multifactorial reasons through the pandemic that may have contributed to that, but people want to look at the data and see what we can say and what we can't say. And so we're working with Aboriginal Medical Services to do that. And then again, another programme of work that came out of the Aboriginal reference group and the kind of conversations about what people are worried about. We found that through another study, we found there's lots of liver disease in people on dialysis. And then there was a lot of discussion about the crossover between renal and liver disease in Aboriginal people and the multifactorial reasons and how you tease that out and how you make sure that people are getting the optimal care for both organs once they're on dialysis, and that has led to another collaborative study called LINK. And then along came diphtheria in the last few months, and so there's never a dull moment in the regional and remote world, and so now we are working with the same partnerships, the same relationships, the same groups of key stakeholders to implement various aspects of the diphtheria response and make sure people that are getting vaccinated. So in conclusion, what have I learned and what do I hope I have shared? I guess as a clinician scientist working clinically as well as in research, you're really in the right place to ask the right questions, to have impact on the ground, and to really follow through that story of implementation. You can use really high-level scientists and partnerships with those groups to ask the right questions, get that information, and then use that to implement on-the-ground solutions. So really, again, the privilege of being able to have that big picture of kind of almost like bench to bedside as the person who is involved on multiple levels in a program of work. There's really no research without service delivery in this setting, and it honestly to me would be quite unethical to do so. And so I think there's such a big role for clinician researchers to be really involved in both aspects. It's a really massive team sport. This is not something you do on your own, and this requires partnerships on all levels, with both ways, bilaterally, with all of the various key groups. You have to listen, and you need to be humble and have humility in terms of me particularly coming from another country, working in a setting that I knew nothing about, and really having to listen and learn about how to be the most effective and the most useful in Northern Australia. And I think it's a real privilege and I very much enjoy being involved in that ground up linkage and translation, and being that person who gets to see both sides, gets to see the actual reality of delivering care on the ground in a remote community, but then also gets to see what's happening in the immunology lab at the Doherty or the molecular virology lab at Vidril when we've been doing the genotype stuff with Hep B. And really be able to facilitate that knowledge to be really filtered down to where it's actually making a difference to people's lives. It's a team sport. There's many people involved in the work that I've just described, and none of it could happen without all of these people. Thank you very much. Happy to take any questions if I've not gone on too long.
Thank you, Jane, for a wonderful presentation. That's very inspiring and fantastic to see and hear. You and I have something in common. I too came to Darwin for 1 year to begin with. That was in 2002, so that was more than 20 years ago. Now, please do put the questions on Slido. There's one question here already. Jane, thanks for a great talk. Can you tell us a bit more about the diphtheria work and how your previous work helped here, and how easy it was to apply or find others to help apply it to a new issue? Great question. Thank you.
Yeah, great question. So, a little bit of the research type stuff that we're setting up is, just a very pragmatic sero survey of people's antibody responses, and then also trying to look at vaccine efficacy. And so looking at a group of people who have definitely had diphtheria and matching them with a group of people who haven't, and looking at, their vaccine history, etc. So very just pragmatic things that we could do quickly with actually currently no resources. So that's the thing, and this is exactly what happened in COVID. Like, you have to kind of do the things that you can do, and then we got the resources later. So I think the partnerships that we have built through the other work, we're really highly reliant on those. And so going to the people that we know what's going on the ground, that the people who we know are giving the vaccines, the people who we know are able to use their kind of position and their influence to spread messages and really enable people to understand what's happening and know what they need to do. So through, for example, we had a kind of out of session urgent meeting of the Indigenous reference group. We presented the diphtheria situation and the epidemiology, and then we discussed the things that we're planning and took on board all feedback in terms of co-designing culturally safe safe ways to do the things that we want to do to get the answers that we want. And, you know, every single time we get such helpful and useful information from the Indigenous reference group conversations that enable us to modify the methodology, to take on board ways to actually implement things that are very clinically useful in terms of success.
Thank you. Another good question here. As a clinician scientist, do you spend more time with patients or in the lab, or is it more of a balance? And I would add to that, has it changed over the year, the proportion that you've done? Because yeah, from my experience, I've had a bit of changing proportions and things. So yeah, what's your experience there?
So I'm roughly half, and I really fight hard to keep my patient contact because I don't ever want to lose that. And so, but you do have to fight for that because I think, you know, the balance does change over time, as Louise said, and you know, the constant search for funding and resources takes up a lot of time. However, the patients and the clinical care is what grounds you, and that's what also enables you to ask the right questions. So personally, I don't want to ever lose that. In COVID, it was very hard to do any research time. I was very much pulled into operational stuff and you know, planning and strategy and policy and clinical and all of that world. So I would say for a good 2 years it was quite hard to keep anything apart from the COVID research ticking along. Like, the other stuff took a bit of a backseat. But I feel like I've got back now to my kind of half.
Excellent, thank you. We do have more questions, but we might keep them for when we're back together on the panel, and we might move now to introduce. Thank you very much, Jane. That was fantastic. It's now my pleasure to introduce our next speaker, Professor Clare Heal. Professor Heal is Professor and Academic Lead of the Department of General Practice at James Cook University School of Medicine and Dentistry. She is based at the Rural Clinical School in Mackay, Queensland. Over the past 10 years, she's been Principal Investigator or Supervising Co-Investigator of 7 successful practice-based randomised controlled trials investigating the management of skin cancer surgery. She's former chair of the Royal Australian College of General Practitioners National Research Committee and a current member of the European Journal of General Practice Editorial Advisory Committee. From 2022 to 2023, she was awarded a Fulbright Scholarship and completed a Master's in Epidemiology at Harvard University. So thank you very much for joining us, Clare, and we look forward to your presentation today. Thank you.
My name's Clare Heal. I'm Academic Lead for General Practice for James Cook University, and I'm going to talk about rural and remote general practice research, which is my area, and also life as a clinician scientist in North Queensland. So next slide. I'll just acknowledge country and acknowledge the Gimu, Walubara and Yindinji people as traditional owners of the land and pay our respects to their elders past and present and emerging, and we recognise their valuable contributions to Australian and global society. So I'm going to talk about my background and also my personal experience with rural research, and also give some tips for research careers for the younger and early career researchers that may be listening to today. So next slide. So my background, so actually coincidentally, I also hail from Liverpool in the UK, like Jane. So I got my MBBS, my medical qualification in 1990, and I actually moved to Queensland in 1992 as a junior doctor. And I settled in Mackay in North Queensland at that time, where I've actually been for the past close to 30 years. But I moved to Cairns 18 months ago. I got my FRAC GP in 2000, and then JCU opened a medical school with a rural clinical school in Mackay, so I became a senior lecturer in 2003. I sort of fell into a PhD. I sort of think of myself as an accidental researcher, so I fell into a PhD in skin diagnosis and management in 2010. And I was lucky enough to get a Fulbright scholarship to do a Masters of Epidemiology at Harvard in 2022, which was fabulous. My current roles, I'm academic lead for GP at JCU and also professor. And I actually progressed from a level A to a level E with staying in the same spot with the same university, which is a bit unusual. And I think is just sort of, you don't necessarily have to move from a rural area to progress your career. I also have a role in exams and assessment and the research. I'm heavily involved with research medical students. And clinically, I work as a GP and currently work in care and sexual health just for a day a week at this stage. I put there in the slide my academic transcript from medical school. Now, I was a terrible medical student and people actually don't believe me, so I finally found my transcript to show people. And our pass mark was 50% at medical school. So this is my transcript for my second year exams, which were our main sort of biggest exams at uni. So I just managed, I always thought I was scraping through, but I didn't, we were sort of pass fail, so we weren't aware of our marks. Yeah, I sort of scraped through medical school. I would have shown you my first year transcript, but I actually failed. So I don't actually have a reflective transcript to show you. So I suppose the message there is that you don't have to sort of be the most brilliant student in the class to have a research career. And sometimes it's just about being in the right place at the right time and having the right research questions. So I'll just go on to the next slide. Great, thank you. So I first got involved in research more than 20 years ago, and I just started as a GP registrar, and there was the RACGP had a research conference in Melbourne, and really I wasn't all that interested in research, but it seemed like a good idea, a good sort of opportunity for travel. So I travelled to Melbourne to this research workshop and was actually quite inspired and decided to do an academic registrar post. And then the project that I investigated as part of that post was about the prevalence, that's the next slide is the right one, about the prevalence of chlamydia in general practice. And this was back in 2002 when genital chlamydia wasn't particularly well known. They'd started to look at screening for chlamydia in the UK. So I enlisted 10 sort of GP colleagues who are actually friends. And probably the research question came from the GPs in the community I was working with rather than from myself. We screened 500 patients for genital chlamydia, young people, and we found that the prevalence of chlamydia was actually 5% in our community of general practice patients in Mackay. And the results of this study were actually used in the GP Red Book, which is the screening guidelines for general practice. So the results of this study were immediately sort of implemented to develop a screening program for chlamydia in general practice in Australia. So it was sort of a good example of sort of immediate implementation. So then I sort of kept going. I then got the lecturer job at JCU, and I think the dean, who at the time was Richard Hayes, sort of asked me whether I was doing any research. And to be honest, I wasn't quite sure what I was supposed to be doing in my uni role. It was all very new to me, but I sort of decided I should probably do some research. And that's when I'd started the Can Sutures Get Wet project. So I'll just go on to the next slide. So we had an evidence-based medicine meeting once a month in Mackay, and the more rural GPs would drive to this meeting, which was a lunchtime meeting, and a couple of the GPs sort of would chat in the car on the way to the meeting, which took them about half an hour, and two of them argued about whether it was better to allow patients to uncover their wound after they had minor skin excisions in general practice, whether it was better to actually allow them to shower and clean their wounds, or whether it was better. It was very important to keep the wounds clean and dry, which for 48 hours, which was the standard guideline. So we did a randomized control trial, and this was very much about engaging a GP community in this research. There were probably 20 GPs and 4 practices, and we actually recruited 1,000 patients, and we allowed one arm of the trial, the patients would cover their wounds for 48 hours, as was conventional, and the other group of patients washed their wounds and were allowed to shower early. And the results of this trial were actually published in the British Medical Journal, which was a huge thrill. So it was the proper British Medical Journal, and it was a leading article. So really, it's the pinnacle of GP research. So that was very exciting. And that's really how I got hooked on research. I'll just go to the next slide. Thank you, Jocelyn. Yeah, so the results showed that wounds could be uncovered and allowed to get wet in the first 48 hours without increasing the incidence of infection. So it was actually an equivalence trial, and we found there was no difference between the two groups. So I'll just go on to the next slide. That's just more of that BMJ publication. So by then I was sort of a bit hooked on research. So I actually was involved in probably up to 10 randomized control trials around the same sort of issues because we live in North Queensland, there's a huge throughput of skin cancer excisions in general practice. And we have no dermatologists or plastic surgeons, or certainly in Mackay we didn't. So the next intervention we looked at was sterile versus non-sterile gloves for minor skin excision. And I'll just go on to the next slide. And again, this was a question that came from mainstream GPs. This is Luke Notley and Andrew O'Neill, and it was their research idea. They wanted to see basically whether we had to use the expensive sterile gloves or whether we could use clean box gloves for skin excisions as far as infection was concerned. And that was a non-inferiority trial, and we found that the non-sterile gloves were non-inferior to the clean box gloves. So I'll just go on to the next slide. Yeah, and the next one after that. Thank you. Yeah, and just to show, so we did a whole series of these trials just to show that not everything always goes to plan. The next study that I wanted to talk about, I did in 2020, was about topical treatments for impetigo. If I could just go on to the next slide. We hit on, again, impetigo's high prevalence in North Queensland, so we thought it would be a great topic to investigate. And they just changed the UK guidelines to use hydrogen peroxide, so an antiseptic as the first line treatment for impetigo. So this was a great antibiotic stewardship study. So we started a pilot randomized control trial comparing topical mupirocin with hydrogen peroxide and Vaseline as a third arm. This is Hilary Gorges, who's one of my academic registrars. RACGP do a great academic registrar program for GPs who want to get involved in research. So unfortunately, we started in 2020 at the same time as COVID started. And in this particular trial, rather than recruiting 1,000 patients, we actually recruited 2. Basically, COVID happened, people weren't going to the GP. The GPs themselves weren't engaged in this project because they had a lot going on, and children weren't particularly going to the GP at all. It was all telephone consultations. But even though this didn't work particularly well, we did come up with some important conclusions in the qualitative component, which was, perhaps that it was better for this type of project with early impetigo. We were restricted to impetigo on the mild end of the spectrum, that would be better to recruit from daycare centres or from pharmacies rather than from general practice if we decided to repeat this study. So I'll just go on to the next slide. I'll skip that one, thank you. Yeah, and just a couple of other projects in important. Because I'm a GP, I pretty much will put my hand to anything. I've got less of a narrow area. I think you have to be fairly broad if you're a GP researcher in North Queensland. So Josh Liu is one of my honours students. So the medical students do 2-year research projects as overload in 5th and 6th year of the course. So Josh Liu looked at secondary prevention for rheumatic heart disease. And I'll just go on to the next slide. And Leah Moncrief is my most recent honours student. She's a First Nations medical student who looked at our syphilis screening programme in the emergency department in Townsville in North Queensland. And basically found that screening for syphilis was basically resulted in treating syphilis, which was close to 1% in prevalence, and actually was cost effective. And yeah, it's wonderful to work with young First Nations researchers such as Leah. So I'll just go on to the next slide and just the next slide after that. So yeah, just thoughts about rural and remote GP research. So there's lots of potential research about specific rural issues. We know that people living in North Queensland and in rural areas have higher rates of chronic disease and higher prevalence of obesity and cigarette smoking and less access to healthcare. But probably my areas have been more about research which has been facilitated by living rurally. So we have a lot more skin cancer and a lot more throughput of skin cancer excisions. And because we're under-resourced from a healthcare point of view, we don't have plastic surgeons and dermatologists. So the GPs tend to manage all skin cancers. So that's sort of formed a large part of my research background, and things like impetigo and otitis externa all are of higher prevalence in the tropics, basically, where I work, and often have higher prevalence in rural areas. So just next slide, and I'm nearly finished. So just enablers for research. Like Jane, I think it's really important to engage clinicians and have them as co-researchers and not just people that recruit patients into projects. It's important to use grassroots questions that come from clinicians, and that's how you get your important research question. And use your unique strengths that you have by living in rural areas. So just, yeah, keep doctor workload for a minimum in general practice research, and just keep clicking. And it's important to find a methodologist or statistician, epidemiologist to sort of help with your research, I think is quite important. And just the next slide, just barriers to research, just keep things as simple as possible because everything's always more complicated than you think it will be. It's important to have academic support. If you live where I live, it's very difficult to get the big NHMRC grants, but there are lots of small grants which are available for you to do smaller projects. Ethics is often a big barrier, particularly in Queensland. Ethics can be actually quite burdensome, so just be patient and know the requirements and be resilient when it comes to publication. And I think I'm on to the last slide now. So yeah, take home messages. Yeah, choose something that you enjoy that sparks joy. I think is probably a really important take home message. And I suppose, look, there's the worthy things about research, sort of improving patient care. Personally, one of the things that's attracted me to research has actually been the travel, which I've really enjoyed, going to conferencing, networking with colleagues, actually having the opportunity to get out of the area that you live in and sort of network and create a broader community. So yeah, enjoy travel if you do embark on a research career. Yeah, and that's pretty much everything from me. Thanks very much.
Thank you, Claire, for a wonderful presentation. It's great to have those different stories from yourself and Jane and see synergies and differences in the roles along the way. But I mean, similar to you in terms of I also went from A to E all in the one location in regional Australia, and I think a lot of us probably do, and yeah, so completely agree with that point. So we've got some good questions here. I think one of these was earlier, but it's applicable to everyone really. Would you say that the remote location allows you to work closer to the cause and the community compared to working in the city in research?
Yes, I would have to agree with that. You're sort of closer to the community. And you also tend to know or particularly when I lived in Mackay, w- I knew every GP in town. Well, I still do, and I still, partly work there. But if you have a smaller community, you know all of the clinicians in town, and you tend to, if you have a good community, you tend to be able to beg favors and work collaboratively. So yes, no, I agree with that statement. Yeah.
Yeah, and I completely agree. The small community really helps with relationships and yeah, and the partnerships. I'm sure that from what both you and Jane were talking about as well. And then there's another question about your role is as a clinician is a GP, and what other clinician roles could you be as a clinician scientist? I mean, I think it's any clinician really, but did you have some thoughts there, Claire, about that?
Yeah, I think any role really. Um, yeah, I think I mean general practice is starting to have a more established route into academia with the RACGP having academic registrar posts, and I'm starting to get more academic registrars. But I think the hospitals have become very good at establishing clinician scientists roles as well, which are often actually a little bit better paid than the GP clinician scientist sort of roles. So I probably other people in the room like Andrew Mallett know more about the sort of the other specialties, the other specialty routes into clinician scientist roles. So they can probably talk about it in the panel session.
Yeah, and I mean we've had presentations from two doctors so far, but clinician scientists covers all clinicians, obviously, including
Yes, of
nursing and
course.
midwifery and allied health and pharmacy. Dr. Davies Tsai is going to talk to us later as well on the panel, and so yes, it covers all clinical roles really. Another question here is that for Claire is, I've found the RACGP ethics committee is easier to deal with than my university's ethics committee because the members of the RACGP's committee and its reviewers have a better understanding of the practicalities of general practice. Which ethics committees have you used? I mean, I think you do have to use your
Yeah.
local ethics committee, is my understanding, but anyway.
Yeah, no, look, I think that's a fabulous comment. So I try and avoid, and Andrew might talk about this, I try and avoid Queensland Health Ethics Committee as much as I can because I find it really burdensome to get through. And then there's the local governance as well. So I tend to use my university ethics committee, the JCU ethics committee, because it tends to be a bit more sensible. But I totally agree. If you've got access to the RACGP ethics committee, that's really smart. And you've found that you've had a good relationship with them. That's a really smart option. So yeah, I think that's a great comment.
We do have some more questions, but I think we may need to move on to our panel now. So thank you very much, Claire, for a fantastic presentation. And we'll now like to ask all speakers to join for our panel. And I'll briefly introduce Professor Jane Davies and Professor Clare Heal will be staying on for the panel, and joining them will be Dr. Danny Tsai, who is the Acting Director of Clinical Research at Alice Springs Hospital and a Senior Research Fellow at Flinders University. He's worked in Alice Springs for over 17 years as a clinician researcher, and his research focuses on antibiotic dosing optimization, particularly in renal impairment and in First Nations patients with critical illness, as well as tackling antimicrobial resistance in remote Australia. And also joining on the panel is Professor Andrew Mallett. He's the Director of Clinical Research at Townsville University Hospital and Professor of Medicine at James Cook University. He practices as adult nephrologist subspecialised in genetic kidney disease and nephrogenetics. So welcome to all panel members, and we'll now start the discussion, and I'll just bring up the questions as well. We might just start with a broad question, first of all, to the panel, and starting maybe with Danny, then Andrew, and then Jane and Claire after that, as you guys have already spoken. So the broad question is, what kind of impact has research had on your career progression, and has it impacted your work-life balance or your lifestyle? Maybe Danny, did you want to have a go first at that?
Oh, research takes time. And I think especially if you are seeking research as a career, that initial phase, it will I think we need to gear up to make sure that we're willing to actually invest time into it. So I feel that like when I did my PhD as a remote PhD student, based in Alice Springs ICU, I was a pharmacist as well, and I was working zero point 0.6 FTE and doing a full-time PhD. And it wasn't easy because back then, like not many people were thinking about research in remote, in a remote service-based, service-oriented hospital. But I was very, very passionate about my work, so I'm happy to do extra time. And I also got married during that time, and I literally submitted my thesis the day before my wife went into labor. So I think I timed it pretty well. Oh, she timed it pretty well. Anyway, so I went off track. But I feel like in terms of work-life balance, I think initially it wasn't easy. So that's why I feel that you need to be extremely passionate about what you do, and I think the passion and the intention, we're doing good for our patients and we're doing good for our people. I think that sort of drives me, knowing that like what we do is able to make a difference. Yeah, I think yeah, but then I'm being able, a lot of people would say that, research is something that you probably invest a lot into it and you don't see a lot, coming out of it. But it might be just a paper, it might be just, it might be just a piece of information. But then if you're able to implement that into your practice, if you're able to translate your finding into practice and make an impact, I think that means the world to me. I think that makes all the difference to me. So yeah, and yeah, sorry. Yeah, thank you. Yeah.
Oh, thank you. That's great. I'll hand over to Professor Andrew Mallett. And thank you, Danny, for telling us a bit more about yourself. Andrew, please do the same as well, because that's a great start.
I mean, research has become a really integral part of my career, I would say. But it wasn't always going to be like that, I don't think. And so I was a late bloomer, so to speak. I didn't do any research to speak of until I was an honours student. Not an honor, God forbid, I wasn't even an honours student, as Claire would remember. I actually, because I was aiming to do a project that was arguably too controversial for the people who would have approved it. But did case reports as a first-year advanced trainee in nephrology, which is very late in the picture. And then obviously found myself as a full professor at 36. So, I think anyone can, get into this space. What I've found has been amazing is that I think that a research career enables you to think very differently, to make big changes that wouldn't otherwise be possible. And it also gives you a lot more portability. So the role I find myself in now was not a role that was ever, on my bingo card, let's say, until suddenly it was. And I was based, actually, I worked and trained at the Royal Brisbane Hospital in Brisbane, and my wife, who's also a renal physician, and we're both from Northern Queensland. We were medical students actually in Mackay, when Claire was a GP in Mackay too. And we were going to be there forever. Brisbane and the Royal Brisbane was our forever place. Until, it wasn't. And so went from being a clinical nephrologist with, research background and working as a clinician scientist to being a director of research and professor of medicine, because opportunity arose. It was a pivot left, having a young family, and I think has then just enabled a whole lot of things to change and grow. And I think that, the great thing is that more and more where you might be physically based matters little in terms of your ability to do clinically meaningful research. Many would say that the kind of research I do, which is focused around monogenic and genetic forms of kidney disease, how can you really do work like that in a regional or rural area? But ironically, actually being in a place like Northern Queensland, or I presume across Northern Australia, you have a lot more breathing room to do a lot more interesting things. And that's been really fantastic as part of the research career that I've seen, kind of really go forward strongly in the last, say, 5 or so years that I've been here in Townsville. Work that I would not have been arguably able to do if I'd stayed in Brisbane. So it's been super exciting, and I reckon the best is yet still to come.
Thank you. Can I just ask what you mean by a lot more breathing room?
I will do my best here, Louise, to be diplomatic. I often say that, as some people will know. So, I mean, big tertiary hospitals are amazing. I work in a regional one right here in Townsville, but, and the Royal Brisbane was an amazing place to work. But big complex hospitals like that are often filled with big complex personalities.
Politics. Yeah.
Yeah, and they regulate each other. The best way for one organizational psychopath to be regulated is another organizational psychopath. Fine. I mean, I think I'm
Hang on, we're keeping it political.
I'm stating fact. But I think that by being in Northern, where I find myself now, there are complex people everywhere we work, full stop. But I think that it's a more can-do attitude. People are looking for reasons to say yes rather than why not. And I think that that's been really great. And I think there is a hunger for change in regional and rural areas that maybe, it's not that it's not there in a metro. I don't want to say that at all, because I think great work still happens clearly in urban and metro Australia too. But I do think as an early mid-career researcher, there is so much more breadth to think differently, to think big, to make big, bold choices, which I worry, and I worked, for 5 or 6 years, as a consultant in one of those places. My experience actually having a direct comparison, I'm not sure I would have been afforded those opportunities there. So I think that, it's a great way to be. And hey, it's amazing to be able to live 5 minutes from my workplace, where parking remains free and easy. And those are great things too.
Thank you. Over to Jane. Did you want to add anything more about what kind of impact research has had on your career progression and work-life balance?
I mean, I think there's pros and cons to everything, aren't they, in every scenario. I think for me, it's afforded me incredible opportunities. I really agree with the travel thing that Claire said. You get these opportunities to go to all these places, both remotely within the Northern Territory, places that I would have never been otherwise if I was just working in a hospital, and also, nationally and internationally to present work. So I think there's incredible opportunities that come along with it. It's hard work for sure. And, my grandma used to say that, nothing that's worthwhile is easy. Like, things that are worthwhile generally require a bit of effort. So I think that in terms of, work-life balance, it's a different kind of pressure to hospital clinical pressure. But yeah, there's definitely a lot of work involved. But if you choose something that you really love and you have that passion for it, then it doesn't really feel like work, is how I see it.
Thank you. And Claire, did you want to add anything to that?
Can you hear me okay? I had to change.
Yes.
Yeah, no, all good. Yeah, no, I agree with what everyone else has said. I certainly, I mean, general practice has a very flat career progression. You become a GP and that's it. But certainly my academic career has been accelerated by living in North Queensland. I became professor much more quickly than my peers did. So yeah, rural life has accelerated and research has accelerated my career pathway. Yeah, and I think academia has improved my work-life balance. GP is quite a grind to work 5 days a week in general practice, and just having that lovely balance where you've got time to think and sit in front of your computer. I mean, some of my colleagues hate the idea of sitting in front of a computer all day, whereas I absolutely love it. So but maybe that's the introvert extrovert in me. So yeah, no, so I think it's improved everything basically.
Thank you. We might go to a couple of questions from the audience. Jane, there's one still from your presentation about a truly inspiring presentation, a great example of how strong partnerships and community-led approaches can drive better health outcomes. The focus on Indigenous leadership and health equity is particularly impactful. I'm curious, have any elements of this model been applied to oral health programs in the Northern Territory?
Oh, oral health programs. Not that I'm aware of. No, we have had lots of requests to use the model for a number of different programs, but not oral health. But happy to chat.
Thank you. And then another broader one, and perhaps Danny or Andrew may want to have a go at this one. I'm currently an undergraduate biomedicine student. How do you recommend taking first steps to enter the research world? Would you recommend roles like interning as a lab assistant, and how would you go about making connections?
Me?
Danny,
I go
Danny,
first?
have a go.
Okay, all right,
Yeah.
okay. So I think for research, I feel that like it's important to do research not just for the purpose of doing research. I think there needs to be a very, very important research question that we're answering. And as a student, I think it might be a little bit hard to identify that. So I think it's important to spend some time with a clinician, or like let's say if you take up a job, an internship job, or I don't know, like biomedical student, like if you're going to work in a lab, you're going to work in the pathology, like use, talk to people who are actually doing research, and then see if you're able to ask to be introduced to talk to someone that is actually doing research, and then to see, and then basically just offer what you can. Like I'm very passionate. I'm happy to spend time. If there's actually a burning question that you like to answer, I'm happy to do the groundwork and I'm happy to lead it. Just to make that connection. Because I have a really really good example. Because a few years ago, there was a medical scientist in our pathology who did exactly that. She said, I just graduated and then I'm just working in our microbiology department, and the manager of pathology introduced her to me and said, hey, she's interested to do some research, and she overheard what I was doing, and she was wondering if there's something that she can help out, something she can lead. And then I gave her the idea. We sat down multiple times. We go through ethics processes, like we went through the whole process, like nothing was formally done, and then eventually we like there was an issue that we're trying to address in our lab, and then we jumped on it, and then she did all the groundwork, she wrote up, and then I helped her, and eventually we published in CMI, which is a fairly good top 10% journal. So yeah, something like that. I don't know if that's
Thank
helpful,
you.
but yeah.
Thank you. Andrew, did you want to add anything to that?
I mean, I think I like the saying that we can all have everything in our lives and careers, just not at the same time. So I think it's finding a time and place for these things. Life is too short, I believe this more than anything else, to do someone else's PhD. So doing something you're actually personally passionate about is really important. If that happens to be that thing that's happening in a wet lab, go for it. If it isn't, maybe not. So I think just, it's about just being selective and careful. And, I try to, I think research-wise, live by the tenet that if it's not fun, I don't do it. So if the prospect of that kind of research or that opportunity isn't something you find intrinsically interesting, fun, stimulating, don't do it to get a line on a CV, because it actually, the weight of it may not be so amazing. But there are tons of opportunities out there. There's lots of amazing, inspirational people doing research who are only too happy to co-design research projects with you. But find something that's fun and stimulating for you, and that it's the right time for you in terms of bandwidth, space, and everything else. Because, it's not about starting research today, it's about starting it at the right time, where you're able to do it in a way that makes you proud.
Thank you. Okay, plenty more questions coming through here. So one for Professor Clare Hill. Strong example of clinician-led rural research translating GP questions into practical trials. Which parts of your model are most transferable to other chronic disease or digital health programs? And how do you sustain a clinician research balance under increasing service and funding pressure? That's a big question.
I might answer the second part of the question because the first part probably isn't. I am doing some AI research at the moment, looking at systematic reviews and using AI to basically conduct systematic reviews, but it's not really my area. And chronic disease management hasn't. I've done a little bit, but hasn't been so much my area as much. The second part of the question was, how do you keep the balance, particularly with reduced funding, I think. So, yeah, and it's really tricky.
Service and funding pressure.
Service and funding. Yeah, so funding is really really difficult for me, actually. So I'd find that the NHMRC, even though they, and the MRFF and those big grants are just over my career. I've only sort of had one of these big grants, which was sort of in collaboration with a group, but I find it really increasingly hard to get funding. So I tend to sort of choose topics. I don't go for sort of the big grants. I go for smaller grants, and I tend to see my role as mentoring younger researchers who may then come up and be capable of getting the bigger funding. But at this point in my career, my role's more to mentor others rather than to attract major funding. But it is becoming tighter and tighter to get funding, I do find, in my own particular area.
Thank you. Maybe this is a broad one to anyone, but maybe Jane, it's your turn. Does living in the community where you work change your perspective as a clinician or a researcher?
Yeah, I mean, I think it, if anything, makes you more invested, especially when you're living there with your family and using the health services that you're trying to make better. So there's certainly a vested interest in making health services as good as they can be for everybody. So yeah, I mean, I think it probably does influence that. You're not as removed as you are in a big tertiary hospital when you go home, I guess. And you also see people that and patients and members of your team and participants in your research in the shopping centre and, at the markets and kind of all over the place. So I think there's definitely more of a connectedness.
Thank you. Some more good questions here. Maybe to Andrew. I was wondering what advice you would give to medical students in rural areas who are interested in research. I've reached out to several researchers, but many opportunities are not suitable for remote involvement. How would you recommend overcoming this challenge and getting started in research? Or maybe Claire. Anyway, Andrew, go for it.
Yeah. No. So it's a good question in that it's clearly a very tricky space. But one of the massive changes that I think has really happened in this last 6 years, particularly since the pandemic, has been that immense virtualization of contact and interaction. And I certainly here in Townsville see lots of medical students who come and see me, they're interested to do something in research. And when you delve a little bit deeper, and it turns out the area that they're really personally passionate about is something, specific or different. And, there may not necessarily be someone in our region who's the right person or someone who's interested similarly. And so I strongly encourage them to either reach out to those person, and they may not be co-located or within your region or affiliated with your university or medical school, and finding that kind of a pathway. At the same time, it's also, working, reaching out to some of those researchers in your area, and particularly if there's someone you have built a relationship with, you can even, I think, very successfully, co-design a research project together as to what that might look like within the feasibility of where you might be, where you're working, and all that kind of stuff. And in my key context here is, at least 3 PhD students now who I'm supervising. So one who completed last year. We didn't meet in person, like at all in person ever, until they were well past their mid-candidature review. Another student didn't meet till halfway between mid-candidature review and their confirmation, and that was by accident at Brisbane Airport. And another student just at a meeting just recently, and they're halfway through their first year. So I think if we're able to successfully deliver research supervision and research higher degrees, I don't think we're asking for world peace for people to be able to navigate research mentorship and co-design using Zoom, Teams, all of these different things. But finding mentors and supervisors who have that alignment with you in terms of interest, who have a generosity and inquisitiveness of spirit that aligns with you too, I think that can be really important. But I don't pretend it's not without challenges. It is, but plug at it is probably the best answer I can give.
Thank you. Did you want to add anything to that, Claire? Or?
Yeah, I totally agree with Andrew. I feel, certainly there's increasing opportunities, and for JCU, there's lots of opportunity for rural research. And in all years of the course, there's sort of increasing opportunities. So I just think keep at it. It may be that particular student just hasn't made the right connection at this stage, or the right connection and the right topic together at this stage. So yeah, I think keep on at it until you find the right person.
Yeah, I agree. Thank you very much. We've got plenty of questions here. Maybe this one for you, Danny. Would clinician-scientists have a job description, or actually have a position as a clinician-scientist, and especially meeting employer expectations and or work outputs? Maybe Jane might like to comment as well. I can see you smiling on that one. Danny?
So I guess as a clinician scientist, it depends on who is actually employing you, because that job description can look very, very, very different. Because at the moment, personally, I'm working on I'm employed by a 3-year fellowship. So basically, my fellowship, as a part of my fellowship, I actually have to come up with my own project, and so I have a lot of autonomy. And basically, I can spend the time however I want, as long as I get the work done. However, if you are employed as a fellow or as a clinician scientist within a group, then what you need to do is dependent on what the group the lead of that group needs you to do. So it's a very difficult to answer question, because every single piece of project is very, very different. Yeah. So
Yeah.
Jane, did you want to say
lots
something?
Lots of different models, I agree, but Jane might like to comment as well.
Yeah, I think there are very different models across different institutions and different hospitals. Yeah. I have 2 separate contracts. So I have a clinical contract and I have a contract with Menzies. And I guess it depends on your kind of bosses and managers within those 2 institutions as to how they implement what you need to do for each of them. But I have generally found across the different areas that I have worked that as long as you're delivering what you need to deliver, there is some flexibility around the crossover between clinical and research in a health institution, and I think that between Menzies and NT Health there is flexibility and crossover as to what that looks like, but strictly they're 2 separate contracts. And I guess, as Danny said, you often have to really get your own salary as a researcher, or I've always had to get my own salary. And so again, that's different in different places. And a research salary is very different to a clinical salary also. So that you need to take that into account as well.
Thank you. So another question here, a broad question to anyone who feels like it is there anything the speakers have seen get easier or harder over time with respect to their locations out of urban centres? Has the context changed, good or bad? Who wants to have a go at that? Andrew or Claire? Andrew, go for it.
I think one thing that has certainly, I feel like may have changed is that it's to be based and working and doing research in a regional rural area is no longer, I think, seen as an impediment at all. I think that the policy and the funding landscape in Australia has been evolving to ensure that there is that better equity of both access and support. And I think our metro cousins as well, increasingly see it as actually as an advantage. And I think that those hurdles, reputationally, policy, otherwise, I think I've all turned. And so I think for early career researchers today, or those looking towards research careers, I hope I'm not seeing being physically based in regional and rural areas in Australia as an impediment in any way, shape, form, or reputationally or otherwise, in a way that I think implicitly once upon a time it may have been. And I think that's been a big shift. We still have a ways to go, absolutely. I still rock up occasionally at meetings and have to remind people I may be from Townsville, but I can assure you I pronounce vowels. I think that but we've made big strides in a compact period of time.
Thank you. What
Sure,
advice
can I
would
add?
Yeah, sure do.
Sorry.
No, go
So
do.
now, okay, yeah. So just adding on to what Andrew was saying, that now that there are a lot of grants now that are only offered to rural remote regions. So for example, there's some MRF, like these big multi-million-dollar grants. Quite a few of them now have two different streams. So one is for everyone, but but the other stream would be only available to projects to be conducted in rural remote region, and then at least 50% of the investigators on those grants need to be from at least an MM2 or to MM7 region. Yeah. So research research will grow in rural remote essentially. Yeah. Thank you.
Yeah. No, thank you. That's an important point. Where was I? What advice would you give a junior doctor or a PhD student considering a rural career? Who'd like to take that one? Claire?
Yeah, go for it, I think. Look, there's some lovely places in rural Australia. There's less competition, to be honest, so which I think Andrew alluded to in some of the bigger places. I've reflecting back, I've had a fantastic career. I've had so many opportunities. I got to go to Harvard. I also got to had a research fellowship at Oxford as well. I've travelled. I've brought up a lovely family, and I wouldn't have done things any differently. So I think my main advice is yes, go ahead and do it.
Thank you. And Claire, while we're with you, there's another one here for you about how do you find the time to be a GP and do research?
Look, I'm not that much of a GP anymore. So, although, as part of my university role, I teach GP, so that helps. So I do keep up with guideline changes and with mainstream general practice, because teaching actually is the ultimate learning, I think. So, that does help. But over the years, I have become less and less of a GP, and more of a researcher. But yeah, the teaching does help you keep up to date, I think.
Yeah, thank you. One here about governance and ethics. don't know who, any of you are welcome. Could you share any tips for maintaining motivation in governance and ethics? I'm a speech pathologist pursuing a PhD in a rural health service, and while I'm passionate about my topic, I'm finding the governance process increasingly frustrating, especially when trying to maintain a 0.6 clinical load. Who would like to have a go at that?
I'm
Andrew,
happy.
you look like you're ready.
Yeah, I'll take a bite at this. Only because like we do operate so in my role we operate a large both ethics and governance unit, and completely understand, and I know that other speakers have mentioned, there are so many challenges here, and I this is a space which fundamentally, I think, in many parts of Australia, including in Northern Australia and regional areas, is transitioning from being, the research police to being more capital F facilitation. And that's a subtle shift over time. It doesn't mean it's not frustrating, though. I think that, it's hard to play any given sport or game without knowing the rules. And so I think particularly in things like research governance, it's really important, and ethics as well. It's so important to go and meet either in person or via phone or virtually the ethics manager or officer or the research governance officer to just go through and ask if they've got checklists. Most of these units, they're details people. They've got lists of checklists, and they will have documents publicly available or otherwise to help you to do that, but follow them assiduously. So, simple things I think that make life easier are having headers, having version numbers, page numbers. And that may seem like, but it's those simple things that those colleagues of ours who work in that space work that they're looking for, that will make your life easier because you're looking for approval. And so it's not about who's right or wrong. It's just about, trying to make sure that you know the rules of the game, that you've had personal connection, gotten tips, even had pre-review from someone in that unit before clicking submit, to try and smooth that pathway. With any submission, I think, as we would all say, you expect a minimum of one round of revisions. That's normal in life. But wherever possible, picking up the phone and reaching out to them. But, at some point, and it's a bit different for all of us, rejection becomes like water off a duck's back. And so you too will enjoy this particular level of nonchalance at some point in your near career. And I hope that it's research governance that breaks you, but it's instead reviewer too. So
Thank you, Andrew. And time has flown. We will need to now finish the panel on that question. Thank you so much, Jane, Claire, Andrew, and Danny, for joining us today. It's been incredibly valuable hearing all of your different career journeys. And thank you, everyone, for all the questions you've submitted. They've really been excellent questions and very well answered. Thank you by all panel members. So in closing, I would like to again acknowledge our partners for their generosity and support of this program here. And for you as audience members, we would really appreciate your feedback. So please do scan this QR code on the screen and submit your answers to a survey here to help us improve our future events. Please let us know if this webinar worked for you and if this series is useful. You can also use the survey to tell us what other topics you'd like to hear more about. And you can also stay connected and follow us on our social media channels for updates on upcoming events and resources. A lot of our Life as Clinician-Scientist content goes on Instagram and LinkedIn, so please consider following us here. So that brings us to an end today, and a final thank you all for joining us today, and thank you to all our speakers and panel members. It's been an incredibly useful and informative and enjoyable discussion, and look forward to hearing and seeing you all again soon. So thank you.